So in Parkinson's disease, right, you have loss of dopaminergic neurons at or in the substantia nigra pars compacta, and the progression, you have a progression, right, is from the brainstem to the cortex. And when that happens, right, so when you lose these dopaminergic neurons in the substantia nigra, you have a decrease or paucity of dopamine in the brain. As a result of that, the brain will then upregulate. So the brain will then upregulate, okay, dopamine receptors. So dopamine receptors. And so this then makes sense that because of this, patients with Parkinson's disease are particularly susceptible to levodopa-induced dyskinesias. So you give a patient with a brain that is already really high in dopamine receptors, you douse their basal ganglia with levodopa, which is just a dopamine receptor agonist. And they have so many dopamine receptors that you get a really, really strong effect. And the effect is that you have your excitatory D1 receptors, and they are going to excite the GO pathway, which is the direct pathway. And your D2 inhibitory receptors are going to decrease or inhibit the no-go signal, which is the indirect pathway. So this is like putting your foot down hard on the accelerator, right? And at the same time, taking your foot completely off the brake. And so the net result of this is that you are going to have uninhibited motor stimulation through the thalamus. Okay, and so the result of that is that you're going to have a dyskinesia, or I'm not sure if I'm pronouncing this correctly, but chorea-like movements. So you're going to have excessive movements. These are excessive, right? Now, that's in Parkinson's disease, but let's compare this to dementia with Lewy bodies. So just like we did with Parkinson's disease, we have loss of dopaminergic neurons, but it's not in the same place. So loss of dopaminergic neurons, we'll duplicate this. We have loss of dopaminergic neurons, but instead of in the substantia nigra, we have it going in from the cortex towards the brainstem. And what is more cortical in its location? Well, the striatum. It's part of the basal ganglia, and so it's above the substantia nigra. You know, if we kind of, I'm going to draw a very sloppily drawn brain here, but here's the brain stem, and you know that the substantia nigra is more at the level of the midbrain, so that's the substantia nigra, and then its circuitry kind of projects up to the caudate putamen, which is the striatum. So that's the striatum. It's still subcortical, but it's higher up. So this kind of helps you understand that dementia with Lewy body starts at the cortex and travels in towards the brainstem, right? Let me draw that a little better. So it's going to affect the striatum, and remember what's on the striatum? The D1 and D2 receptors of the basal ganglia circuitry. So what you have with dementia with Lewy bodies is you have first striatal loss of D1 and most notably D2 receptors. And when you lose the receptor, when the receptor is what is in a deficit rather than the neurotransmitter or dopamine, then there's a kind of different result. So you do not have, most notably, so there is a lack of dopamine receptor upregulation, okay? Because these dopamine receptors are being destroyed by, aggregated Lewy bodies, okay, that are being deposited in the striatum. So you have a lack of dopamine receptor upregulation. And when you don't have those dopamine receptors, when they can't be upregulated, you won't get what you see here. Right? So there's actually a different test that you can do here, which is you can test, rather than testing for a sensitivity to levodopa, you can test for a sensitivity to a neuroleptic / antipsychotic. Why neuroleptic and antipsychotic? So neuroleptic / antipsychotic sensitivity. Why can you test for that? Well, because neuroleptic / antipsychotics are dopamine receptor antagonists rather than agonists. Okay, so when you antagonize a system that is already lacking dopamine receptors, you are going to worsen the patient's condition from a Parkinsonian perspective. So the very few dopamine receptors that a patient with dementia with Lewy body has are now going to be blocked. And so you're going to have pretty much the opposite of here. So if we kind of copy this, right? Okay, we can duplicate this. So you're going to have pretty much the opposite occur for this. Let me just fix that. So instead, what you're going to have is your D1 excitatory receptor, you're going to have less. So you're going to have less of a go signal. So less of a go signal. And then you're also going to have this D2 receptor is not going to be activated, and so you're going to have more of a no-go signal, because remember that D2 naturally suppresses the no-go signal. So if you have less D2, you'll have more of a no-go or uninhibited no-go signal and less of a go signal. And so this is the equivalent of taking your foot off the gas pedal and slamming it on the brake pedal. And so instead of uninhibited motor stimulation, you are going to have heavily inhibited motor stimulation. And when you heavily inhibit your motor signals, instead of having excessive movements, you are going to have, you're basically not going to be able to move. And so you'll have anywhere from drug-induced RX or drug-induced Parkinsonism, right? Because Parkinson's is characterized chiefly by bradykinesia, or these decreased movements. And it can even range to something that we call neuroleptic malignant syndrome, which is covered in a different video.